Sayın hocalarım, değerli meslektaşlarım, şimdiki konferansımızın konuşmacısı Amerika Birleşik Devletleri San Francisco'dan Kaliforniya Üniversitesi San Francisco Mount Sinai Hastanesi'nin öğretim üyelerinden Sayın Profesör Quan-Yang Duh. Kendisi çok aktüel bir konuda bizlere bir konferans verecek. Bu da papiller mikrokanserlerde. Rezeksiyon mu yoksa aktif gözlem, gözetim ya da takip mi? Bu konuda kendisini dinlemekten büyük bir zevk alacağız. Quan, may I invite you to the podium, please?
Good morning. Thank you very much for inviting me here. It's great to come to a beautiful area like this and to see many old friends and hopefully to make some new friends. And again, I'd like to be here and I hope to learn a lot from your Congress here. And I apologize that I do not speak Turkish, so the lecture will be in English. You know, internet is a wonderful thing. I'm able to find out more about Earl Duran than he probably care for me to know. And he actually has a website. I can get his picture and everything. And with Google Translate, I can actually know a lot about him. But the thing that we share is that Earl Duran obviously is one of the most prominent endocrine surgeons in Turkey, and has been a good friend of my own mentor and teacher, Dr. Olo Clark, and you can see that they share the education with Professor Selwyn Taylor there in Hammersmith. And we also share a lot about being members and counselor for the International Association of Endocrine Surgeons. The reason I put the 1994 director of German hospital there is there's a story I want to tell you. I came to visit Dr. Duran, and I went to his hospital in the German hospital, and I say, I'm here to see Dr. Duran. And the nurses say, oh yes, of course, we want to go see Dr. Duran. So she took me to a room, and she said, please take off your clothes. She said it in Turkish, but I understood what she wanted. So I took off my clothes. She said, no, your pants also. And I said, well, that's a very strange thing. In the United States, when we operate with our underwear on. I said, well, that's okay. So I put on the gown. And then she said, please climb on the bed. And so it was a surgical bed. So then I realized that she thought I was one of Dr. Duran's patients for operation for the day. And if I didn't stop her, I probably would have had an incision somewhere by Earl. So. Anyway, it's great to be here in your honor, and it's quite an honor for me to be able to be here to give this lecture. So today I'm going to talk about papillary microcarcinoma. I'm going to emphasize several issues here about the increasing incidence and possible overdiagnosis of papillary microcancer, about its excellent prognosis, and that active surveillance, non-operative treatment has become acceptable in the United States, and operations are becoming more conservative. So there are three names that I will be mentioning during this lecture that will be important. One is Professor Gilbert Welch, who is a professor of medicine at Dartmouth Hospital. One is Professor Fujimoto, who was a president of International Association of Endocrine Surgeons. And the last one is Professor Hira Miyauchi, who is also a Japanese surgeon. And some of the story that I will tell you will be told by some of these people. So there's obviously an epidemic of thyroid cancer going on in the world. And this is American data. As you can see, over the years, the number of papillary thyroid cancer diagnosed in the United States have increased significantly. And this is not just in the United States. This is the same in China when I go there. This is the same in Europe. So, and in fact, if you look at the increase in the papillary thyroid cancer, this is the data from the United States, and most of the increase are due to the smaller cancers, those that are between 0 to 2 centimeters. This is from the Sears data, and you can see that there's a 9 to 10% increase per year of papillary thyroid cancer that are smaller than 1 centimeter. Now keep in mind that there's still also real increase in thyroid cancer, that there's still about 3 or 4% increase in T3 tumors and in metastatic disease. But most of the cancer that we see that's increasing in thyroid cancer is due to microcarcinoma. Now, there's concern that with the overdiagnosis, we will have overtreatment of these patients. And so I want to tell you how Dr. Welch talked about this. He's a Dartmouth Medical School professor, and he's an expert in overdiagnosis. And he said, we assume that cancers are all like rabbits, that you want to catch them before they escape the barnyard pen. But some are like birds. The most aggressive cancer have already taken flights before you can discover them, which is why some people still die from cancer, despite early detection. And lots are like turtles. They aren't going anywhere, and removing them would not make any difference. And every cancer has a different ratio of rabbits, turtle, and birds, which make the story much more complicated. He went on to say that for cervical cancer and colon cancer, many of the cancers, if you catch them early, you can prevent bad things. But for prostate cancer and breast cancer, probably not the case. In fact, if you look at one of his studies here that shows, interestingly enough, for prostate cancer, there's some decrease in metastatic disease after the PSA studies have become available. But for breast cancer, after beginning of widespread use of mammography screening, there's really no change in the incidence of metastatic disease. And that's very similar for thyroid cancer. As I show you, most of the thyroid cancer we see nowadays are much smaller. So this is the data from Korea. So what happened in Korea is starting in 1999, they began a national screening program for various cancers, not specifically for thyroid cancer. But what happened was that ultrasound became widely available for people to use. And during that time, many patients were then being screened for thyroid cancer. And it became the #1 cancer in the country of South Korea. And more than half of these cancers were smaller than 1 centimeter, and more than 25% was smaller than 0.5 centimeters. 2 out of 3 patients got total thyroidectomy, and unfortunately, with this operations, 11% of the patients were hypopara, and 2% of the patients had vocal cord paralysis. And this became a major concern. If you look at the data, that's the same curve that I showed you from the United States, except much more dramatic increase. And then if you look at the picture on the right, the number of patients that got diagnosed with thyroid cancer exactly paralleled the availability of ultrasound machines that's available in Korea. So once this issues of overdiagnosis and overtreatment was pointed out, you can see that there, after 2013, when the New England Journal article came out, the number of thyroid cancer diagnoses in Korea began to come down because people were warned not to use ultrasound routinely to screen for thyroid cancer. It's a very interesting concept because as surgeons, we have always been taught that we should find those cancers early and get rid of them so they won't harm our patients. But if you go back to the concept of Gilbert Welch, finding a bunch of turtles are not going to help your patients because these may be cancers that would never develop into anything. So let's talk about how likely papillary thyroid microcancers will cause death in your patients. So this is a CS data from 1988 to 2007. There were almost 20,000 patients and fewer than 50 deaths. This comes down to a disease-specific survival of 99.5% over 10 years. So, and this is very interesting. If you even study these deaths, you can see that the deaths are correlated to 5 different risk factors here. Older, men, minority ethnic status, extrathyroidal extension, nodal metastasis, and distal metastasis at presentation. So if you look at these, at least 4 out of the 6 predictors are the same as the TNM classification, meaning that if the patient presents with high-stage disease, they are going to be more likely to die. And so this is very interesting data. Now, if you look at this same data about 10 years later from 1998 instead of 88 and about 3 years later to 2010, you find that these patients, the microcarcinoma patients, 73% have total thyroidectomy, 31% have radioactive iodine treatment. So this is very similar to the Korean data. Again, the disease-specific survival is 99.6%. And the disease survival, the overall survival is the same as the age-matched population in the United States. So this is not a deadly disease. So, but if this is not a deadly disease, a few people still die from it. So can we tell who those few people are going to get into trouble with their microcancer? So this is where the Fujimoto classification is very, very important. Professor Fujimoto talked about symptomatic versus asymptomatic micropapillary cancer. So this is a 1999 article that they reviewed their cases of microcancers, and what they found was that of those patients, all the patients with distal metastasis and cancer-specific death happened in the 30 patients who had symptomatic papillary thyroid cancer. And the way he defines it is that these patients already came to your clinic with palpable cervical lymph node metastasis or with already a paralyzed recurrent laryngeal nerve. So the bad cancers are very obvious from the very beginning. And you can see that people with the extranodal extensions or lymph node metastasis have a much worse prognosis than those patients that are presented asymptomatically. In fact, if you look at the asymptomatic curve, it is a flat curve. In his experience, nobody ever died of an incidental papillary thyroid cancer that just happened to be found and the patient is asymptomatic. So in fact, subsequently, the next year, this is another one of his papers, he classified the patient into, during the original presentation, they look like they're in trouble, more aggressive disease, and then separate them out into the other group. And essentially what he would tell you from this paper is that there's a group of patients that he calls it type 1, that these are very, very low risk. And in fact, in Gilbert-Welch terminology, these will be what we call turtles. 95% of the micropapillary cancers will be turtles. And if you look at the ones that died, these are the birds, and they're less than 1%. And then there's a small group in between. Those are the rabbits. Those are the ones that if you catch early, you can help your patient. But you need to look at the proportion of these cases. That overwhelmingly, these cases tend to be not very aggressive. There will be a few that are very aggressive, and then the group in between. That's where the surgeons should be concentrating on, not the one at the top. Okay. So, now let's review the data from Japan about microcancer, what we call the KUMA protocol. So the Kuma protocol was started by Akira Miyauchi in 1993. And Japan was many years ahead of Korea and the United States and probably in Europe. They were using ultrasound for a long time. So they have been dealing with the issues of what do I do when I find these small cancers and I'm not quite sure an operation is helping these patients. So he started a program of observation for these patients. And as long as the patient is low risk, and what he means by low risk is that these patients have not presented with lymph node metastasis or distant metastasis, don't have extrathyroidal extension. Again, the Fujimoto symptomatic patients, they were not observed. Or if the tumor is located too close to the recurrent laryngeal nerve, on ultrasound, the posterior lesions, because if they grow, they can cause trouble. And or if the cytology is high grade by needle biopsy. And he would operate only if they grow 3 millimeters or more, or they develop new lymph nodes. And after 10 years, and now the follow-up is some of them as long as 20 years now, only about 15% of the patients had operations. There were no deaths from thyroid cancer, no recurrences except for one patient. And if you review his data, this is quite interesting. Over 10 years of observation, 8% of the patients would have the thyroid nodule grow by more than 3 millimeters. Over 10 years, about 4% of the patients would develop new lymph node metastases that can be seen on ultrasound. And in fact, total, about 7% of the patients, the disease becomes clinical. And these are the patients that got operated on. So most people do quite well. Now, interestingly enough, if you separate out the group into the younger patients and the older patients, now we would usually expect the older patients to do badly and younger patients to do well. And actually, what is very interesting is that the tumor that grew tend to be in the younger patients. The older patients in this group, if you were older than 60 years old, after 10 years, nobody's cancer grew by 3 millimeters. This is very interesting. For older patients, older than 60, if you find a microcancer and you watch it for 10 years, it does not grow. So in fact, with this data, I also work at the VA hospital. There are a lot of old men, and we do a lot of ultrasound, and we find very small cancers. Nowadays, when I see a small cancer at my VA hospital with an old man who looks like low risk, I tell the guy, I say, I can operate on you, but more likely, something else will get you before your thyroid cancer. So we don't have to do an operation. Interestingly enough, if you look at lymph node metastasis, the younger patients actually also develop more lymph node metastasis over time. So this is the data. If you're younger than age 40, after about 15 years, 30% of the time, you would develop new lymph node metastasis. So when I see a young patient, a 35-year-old patient, with a 7 millimeter papillary thyroid cancer in my clinic, what I tell that patient is, you don't have to have this operation in a hurry. However, if I watch you for another 10 years, there's about 20 or 30% chance that that cancer will grow or you will develop new lymph nodes and I will need to operate on you. So let's find the right time to operate on you. If you really don't want to have an operation, we will continue to follow you. But keep in mind that there's about 1 in 3 chance you're going to get an operation sometime in your life. So now let's talk about lymph node metastasis in patients with micropapillary thyroid cancer. And here, our Japanese colleagues have also taught us quite a bit. This is Wada's paper from Annals of Surgery in 2003. And what he found was that patients with micropapillary cancer, if you do relatively aggressive operation, which is complete central neck lymph node dissection and complete lateral neck lymph node dissection, how often would you find lymph node metastasis in this patient? It's 64% for the central neck, 44% for the lateral neck. Now this is completely different data than what I just told you. I told you that these patients rarely develop lymph node. Now this is very different. Remember, these are very small lymph node metastases that you can find on pathology, but not necessarily on presentation on ultrasound. In fact, if you separate out the group into therapeutic dissection versus prophylactic dissection, and concentrate on those only for prophylactic dissection, meaning that there was no obvious cancer in the lymph nodes, but they went ahead and removed the lymph nodes, 61% still will have positive lymph nodes in the central neck, 40% positive lymph nodes in the lateral neck. Interestingly enough, you look at nodal recurrences for this group of patients. If the lymph node dissection was done because the patient presented with lymph node disease clinically, the recurrence rate is about 17%. But if the lymph node dissection was done in a prophylactic manner, only 0.43% of these patients will have recurrence. And there's a comparison group of patients who had thyroid operations without lymph node dissection for microcancer. And guess what? The recurrence rate is exactly the same. Whether or not you do a lymph node dissection in patients with asymptomatic microcarcinoma, their recurrence rate in the lymph node is somewhere about 0.5%, no matter whether you do a prophylactic lymph node dissection or not. So the interesting thing is this: probably lymph node metastases, just like microcancers, most of them behave like turtles. If you leave them alone, nothing happened to them. So this is a paper from Craig Randolph on behalf of American Thyroid Association, ATA, that talk about different lymph nodes. Currently, the TNM system for lymph node staging, it's either N1A, which is central node, or N1B, which is lateral node. But I think within the next few years, it will be changed, because lymph node metastases are not all the same. Again, some are turtles, some are rabbits, and some may be birds. So if the patient is clinically M0 and have micrometastases that's smaller than 2 millimeters, fewer than 5 lymph nodes, their risk of recurrences is actually extremely low. It's in the range of less than 2%. However, if they have high-risk disease that are clinically obvious, even after dissection, or if they have lymph node metastasis that's larger than 3 centimeters, or they have more than 5 lymph nodes, their long-term recurrence rate is much, much higher. So again, not all lymph node metastases are the same. And those that occur in microcarcinomas that are very small, very few, and don't have extranodal extensions probably are not that bad a problem for your patients. So let's review what the 2015 American Thyroid Association guideline says. So in general, in the United States, it is recommended that everybody with thyroid nodule gets an ultrasound, and you look at what the ultrasound looked like and classify the nodule into a high risk or low risk disease. And then you do a needle biopsy. If it's very high risk, you biopsy it at 1 centimeter. If it's very low risk, you biopsy it at the threshold of about 2 centimeters. And then you divide them out into whatever the cytology that's found. Interestingly enough, in this scheme, there's no specific recommendation for biopsy of nodule that's smaller than 1 centimeter. So in the United States, you do not have to biopsy a nodule that's smaller than 1 centimeter. In fact, you need to have a specific reason you want to do that. You see a big lymph node on the side and you think that's a papillary cancer, you could also biopsy the cancer itself. But otherwise, there's no requirement. And in fact, a separate organization, this is the NCCN from the National Cancer Institute, and again, in the recommendation, there's nothing about smaller than 1 centimeter. So you don't have to biopsy those that are smaller than 1 centimeter. In fact, this is a recommendation from the APA. Nodule larger than 1 centimeter with high suspicion, nodule more than 1.5 centimeter, nodule more than 2 centimeter with very low suspicion. Again, it does not tell you you have to biopsy anything that's smaller than 1 centimeter. In fact, it specifically said needle biopsy is not required for nodules that do not meet the above criteria, which means nodules that are smaller than 1 centimeter. However, here's another recommendation. If you do a needle biopsy and the result is diagnostic for thyroid cancer, surgery is generally recommended. Now, however, it also says an active surveillance management approach can be considered as an alternative to immediate surgery. It says immediate surgery. Doesn't mean that these patients will never have surgery. Just say they don't have to have a surgery right away. And a patient with a very low risk tumor. So here it gives an example of papillary mikrocarcinoma. But these have to be papillary mikrocarcinoma without the clinical evidence of metastatic disease or local invasion and no convincing psychological evidence of aggressive disease. So these are the Fujimoto asymptomatic patients, or most likely the turtles. Okay? Now, a few of them can be rabbits. We got to follow them. So now, interestingly, now this is another change that's happened quite a few years ago, not just recently. That those cancers that you find that are smaller than 1 centimeter, without other obvious lesions, it is acceptable in the United States to just do a lobectomy without any prophylactic lymph node dissection or without the need for total thyroidectomy. Now, there are some risks that one can think about. So what about family and familial thyroid cancer, patients with familial disease? If you look at familial cancers on the left-hand side, those have familial disease but smaller cancers have better prognosis than those that have familial disease with big cancers. And in fact, if you have small cancers, whether or not you have family history, which is on the right side, the results is about the same. So family history would make your patient have worse prognosis if the cancer is larger than 1 centimeter. But family history by itself does not add to the risk of the patients that have small cancers. We don't know exactly what the explanation for that is. What about molecular testing? What about BRAF? A lot of centers now routinely do BRAF analysis for these patients. And if you look at the data from BRAF, you find that the risk of lymph node recurrence is about twice as high if somebody has BRAF mutation. And here you see the data is mostly influenced by those two studies there. So the odds ratio is about 2 for patients who have lymph node recurrences. So if your biopsy, needle biopsy is BRAF positive, you want to worry a little bit more about those patients. However, in San Francisco, 75% of our papillary thyroid cancers are BRAF positive. In Korea, 90% of their papillary thyroid cancers are BRAF positive. So under that type of circumstances, knowing BRAF probably does not help you very much about your decision. So now there are some areas that you still have to be careful with. The story is not finished yet. Okay. How often do we find unanticipated high-risk characteristic on final pathology in somebody who is apparently low-risk disease? Because we're talking about watching low-risk disease. Now, we don't know about following low-risk disease in smaller than 1 centimeter, but this is the data we have from San Francisco on following if we were to do a lobectomy only. This is lobectomy now, remember, for smaller than 1 centimeter cancer. If you only do a lobectomy for patients that are between 1 to 4 centimeters with thyroid cancer, there are various probabilities there of how often you will find what appeared to be aggressive characteristic that was not obvious from preoperative evaluation. So this became obvious when the new APA guideline, which I did not get into, of allowing 1 to 4 centimeter thyroid cancers to be operated on only with a lobectomy. And what we found is this: if you have somewhere between 2 to 4 centimeters, there's about almost a 40% chance that one of these things will be found in the patient. If it's between 1 and 2 centimeters, it's about 30% chance. And my guess is smaller than 1 centimeters, there's about 20% chance you will find one of these characteristics. Now maybe they are not as important, but I think the aggressive histology is important. What we don't know is whether or not any of the other things are also important. But the problem is this: if your pathologist or if your referring endocrinologist think they're important, these patients will be sent back to you for a completion total thyroidectomy. So before you start doing lobectomy only for these patients, you have to know ahead of time how likely is it, how aggressive is on the other people that you work with, your endocrinologist, so that you don't end up with having different ideas about how you want to treat these patients. Another thing is that there's some recent data of active surveillance that's been published in Korea. Now this is just only published online, not in print yet. This is a Korean study. So they did exactly what the Kuma Hospital did. They took 192 patients, they followed them more than 1 year, 2.5 year median. These are very small cancers, 5.5 millimeters. And what they found is quite interesting. Over the median of only 2 years of follow-up, they have tumor sizes that are staying the same, most of them about 70%. There's some that actually got smaller, but 14% of them got bigger. So this is a little bit more than what the Kuma Hospital data show, although most of these are not larger than 3 millimeters. So again, you have to be careful knowing what you're watching. Now, over this time, about 10% of the patient got operated on. And interestingly enough, look at the main reason why these patients that they were watching got operated on. The patient got too worried about following cancer. So they ended up having an operation. Half of these patients got an operation because they got tired of watching a cancer in their thyroid, and they're afraid. So you have to know how likely is it that your patient may want to follow a conservative treatment. They may not like to have a thyroid in the neck. Some of them grew, only one of them developed new lymph nodes. But here's a cautionary thing. Of the 24 cancers that were removed, 2 of them were tall cell cancers, 15 had multifocal disease, 9 of them had extrathyroidal extension, and 7 of them have central neck lymph node positive. So this is not nothing. Remember I just told you. They thought these were low-risk patients, that's why they were following. But when the operation was done, they saw some high-risk characteristics. So I don't think the story is completely told yet, just about how safe it is to follow these patients. So I can summarize for you what I just told you now. Increasing the incidence of papillary thyroid cancer is all over the world. There's concern about overdiagnosis. Most of these, 95% of them, will be behaving like turtles. You don't have to catch them. Nothing will happen to them. Okay? A few are very aggressive at presentation. Those already have lung metastases, etc. These are birds. And some of them will grow and develop nodal metastases. And these are the ones that you try to catch. These are the rabbits. Active surveillance is okay for low-risk patients. You need to have good ultrasound, and you need to look at the clinical presentation of the patients. Think about whether the patient is Fujimoto symptomatic or Fujimoto asymptomatic. Keep in mind that microcarcinoma progress very slowly in older patients. So if you have some old man with a 7mm cancer who has terrible heart disease and lung disease, you probably should not be operating on that patient. Keep in mind that there may be unanticipated pathology, that when these things come out, they may have more aggressive features than you like. We don't know how useful molecular testing is. And for resection, I think a lobectomy will be okay, but keep in mind that you may have to do a completion total thyroidectomy in some patients. And I'm going to wrap up with a quote from Blake Cady, what he called the basic principle in surgical oncology. Biology is king, selection is queen. Technical maneuvers are prince and princesses. Occasionally the prince and princess try to overthrow the powerful forces of the king and queen, sometimes with temporary apparent victory, but usually do no long-term avail. So, again, for papillary microcancer, resect it if it looks like a rabbit to you at presentation. Most of the other ones will be turtles, but some rabbits will be hiding in there, and you need to do active surveillance to find them. Keep in mind that we make assumptions that these turtles don't become birds, okay? And another thing that I didn't have a chance to tell you about is whether or not surveillance is more cost-effective than resection, because it still may cost a lot of money to watch these patients. So, thank you very much, and it's quite an honor to be here to talk to you.
Thank you, Quan. Let's start with the audience first, if they have some questions, okay?
Of course.
Evet, salondan soru varsa alalım.
About 20 years ago, Mr. John Harden said to us, whatever you do, high concentration every time you come to metastasis. How can we separate like this patient? Which one is need more aggressive operation? Which one is conservative operation? Any specialist. Sometimes we learn the pathology post-operative. Capsule invasion, micrometastasis, and something else.
Well, you know, I don't think we solved that problem yet. But one good thing that you do know is looking at the Fujimoto data, you know that those that are going to be aggressive, most of them show up very aggressive in the first place. So you know them already. The patient comes to your office talking like this. You know, even if he has a microcarcinoma, that's not a very good microcarcinoma. The one that you can feel in the neck that have lymph nodes. It doesn't matter they have microcarcinoma. So I think there's a group of them that's already selected out upon presentation. So you just need to not be blind by the fact they say, oh, I had a patient who had microcarcinoma on ultrasound, but had already lymph nodes. It came to me with the New York Times article. Says the New York Times says I don't need an operation. And I say, I'm very sorry, yours needs an operation. So most of them, I think at the beginning, you would know. Now, the key question that you're asking is, how do we know which one are the bad ones? Okay. Personally, I believe that probably molecular biology will help, because we're getting better and better at this. And so probably very soon we get needle biopsy, and not just for BRAF. I don't think BRAF itself helped that much. But you will probably take that cytology and process it through some kind of molecular genetic testing of various types. And we'll talk about that tomorrow again in one of the sessions. And I think we'll be able to predict another group that are probably going to be higher risk for developing bad things. And then some kind of clinical judgment thing about following, for example, older patients. Probably you don't have to be as aggressive. For younger patients, you have to be more aggressive because you know they will have more chance to develop lymph nodes. Although they don't die from them, they're going to become clinically more obvious. So, great question.
Başka sorusu olan var mı? Buyurun.
Dr. Yavuz from Diyarbakır. Thank you very much for this nice presentation. Micropapillary carcinoma is a difficult area. In my recent experiences, I only see this from pathological reports. I checked, the number are not very too many, and we don't have too many numbers. So, what is the best diagnosis? My question to diagnose this patient. Final aspiration, we should do, how we could trust this result. It's always a serious problem. What's the best diagnosis? And once you diagnose, okay, survivors, you said it is, I noticed your slides, is okay, but is a concern, is patients get very anxious and surgeons anxious, malpractice is very important point. So, first question, the best diagnosis for micropapillary carcinoma, what's the best method? And for survivors, in very short sentence, what would you advise us? Thank you very much.
Great, thank you very much for the question. If I understand you, I think there are two types of situations. One situation is you find a microcarcinoma on final pathology when you operate on somebody who has multinodular goiters. So you find a 3 millimeter papillary thyroid cancer. I tell the patient, and this is even before the debate here that we had about what to do with preoperatively, if somebody did not have clinical concern for thyroid cancer and they happen to have a micropapillary cancer, we don't consider that cancer at all. In fact, we just tell them it's an incidental finding. And in many countries that have studied that, in the United States, 5% of all thyroid, if you do it on autopsy, will have small cancers. But people are not dying, those patients are not dying from thyroid cancer. So I tell the patients, the pathologists find a small cancer in your thyroid, but these don't usually behave like cancers. So don't consider it like a cancer. But you should know about it so that if an unlikely scenario or something happened, you know. Now, what do I do with somebody who shows up in my clinic because somebody did an ultrasound and find a 6 millimeter nodule with microcarcinoma in it? First of all, I do the ultrasound myself again, and I look at it to see whether I consider this a high risk or low risk thing. If this is very posterior, I would try to tell the patient that I think an operation would be very important, because this is not a low risk situation like we read in the newspapers. Okay. Now, if this is a low risk situation, I would tell the patient exactly what I just told you now, but in a shorter sentence. I would tell them that 95% of these will behave like turtles. I can catch them, but they probably won't do any good for you. 5% of them will become rabbits, okay? And I can prevent them if I take it out. But keep in mind that I would tell the patient, I'm a very good surgeon, but if I operate 100 times, 5 patients will have vocal cord problems, and 1 of those 5 will be permanent. The other 4 will get better. So I want them to balance the risk versus benefit of what I do for them. Also, if I do a lobectomy on them, almost 50% may require post-operative treatment with thyroid hormone. So again, I let the patient help me make the decision. It's not a decision made by myself. My job is to give the patients the numbers, and so they can decide what will be the best thing for them to do. And interestingly enough, in my own practice, it's about 50-50. About half of my patients say, of course, I don't want an operation if that's what you told me. The other half will say, of course, I want an operation. Very interesting. People's decision is not the same as yours. I don't know what I would do if I were given the same information, but people actually do think about these things differently. So that's my recommendation. Talk to your patient. Oh, about malpractice. I think if you talk to your patient properly, malpractice is not an issue.
Arkada bir soru var da. Siz soru mu sormak istiyordunuz arkadaşlar? Evet.
When you offer active surveillance, do you perform final aspiration or you just assume it's a microcancer?
I think in general you can do both. But however, if you look at the Japanese follow-ups, they always do a needle biopsy to know that it's a papillary thyroid cancer, then follow it. Because even though ultrasound is relatively good, it's not exactly precise. So for a real proper active surveillance program, you should probably biopsy it and then do active surveillance. Having said that, I have seen patients with small, what appear to be papillary thyroid cancer. I have told my patients it's up to them whether or not they want a biopsy. Because it is possible. I think if you saw the number of half of the people that get an operation because they have anxiety about having a cancer. Is the anxiety more if I prove that it's a cancer, or they can imagine that maybe this is not quite a cancer? I don't know. But if you want to do a proper follow-up program, you probably have to do a biopsy. If you want to publish a paper 10 years from now for your active surveillance, if you don't have a biopsy, people probably won't believe you that you'll be following a cancer. But clinical practice, I think, is a little bit different.
But we would like to know if there is a poor prognostic type of papillary cancer. So I think biopsy is doing biopsy is good for rule out just to rule out poor prognostic types. Sometimes cytology could give additional information.
Yeah, I think right now we don't have enough to know that, in fact, many of these things, there are very few, even though we put it there for high-grade cytology, very few are going to come back with high-grade cytology. That's just the numbers. However, I think as we get better with related to the first question that we tried to answer about molecular genetic testing, I think that would eventually make it so that we want to test it on everybody. See, right now we still don't have the tools. All we have is it's a papillary cancer. But if we have the tools to say that, well, you know what, this is a papillary thyroid cancer, and not only this is a papillary thyroid cancer, it has a BRAF V600E mutation and a TERT promoter mutation. And we know these patients behave really poorly. So in that case, you will want to be more aggressive and not follow the patient. Or if you get a needle biopsy and say, yeah, this is a cancer, but it does not have any obvious mutations that we can see that's aggressive, and maybe we can do a better follow-up. I think that's, in the long term, that would be the answer. And when we have the molecular genetic testing available, we will probably want to make sure we biopsy every single one. Thank you for your question.
Başka soru yok galiba. Bir soru daha var.
Thank you. What do you think about corneal thyroid biopsy? Do you prefer to use fine needle aspiration biopsy?
Well, in terms of, the question is regarding core needle biopsy versus fine needle biopsy. In my own practice and in most places in the United States, core needle biopsies are rarely used. Most of the time we use fine needle biopsy, and the reason is specifically for papillary thyroid cancer, it's relatively easily diagnosed on cytology. I think core needle biopsy may have a role in some very difficult to diagnose patients. So instead of doing a lobectomy, you can do a core needle biopsy. And again, tomorrow we'll talk a little bit about some of the molecular testing for these. And so in my own practice, if my fine needle biopsy I'm not happy with, I will probably, like indeterminate type thing, I will probably use molecular testing rather than core needle biopsy. As you know, it's really not that dangerous, but it does carry a little bit more risk of potential hematoma, and the patients don't like it as much because of symptoms. But thank you very much.
Evet, başka soru yok galiba. Quan, if you please stay for a couple more seconds on the podium, we will do the ceremony.
Okay.
Sayın Profesör Quan Duh'a çok teşekkür ediyoruz katkılarından dolayı. Organizasyon komitesinin şükranlarını ifade etmek için sunacağımız bir plaketi var. Aynı zamanda özel kardeşini de podyuma davet ediyorum. O da Erol Hoca'yı alıp podyuma gelirse ona da vereceğimiz bir plaketimiz olacak.
Gösterdiğiniz